Good evening, everybody. I think we are live with great relief, I have to say. It's very nerve-wracking when you know you've got technical difficulties and people are waiting. So apologies if you've all been hanging on, waiting for this event to start. We've had some technical gremlins going on, but I think we're all good to go now. So good evening to everybody who's watching tonight live, and to those who may watch it later on. I'm Ailsa Bosworth. I'm NRAS's National Patient Champion at NRAS. And this evening, I'm delighted that we're going to be showcasing an important new service which has been trialled in remote monitoring in rheumatoid arthritis across South London, and which NRAS has been supporting over the last 2 years or more. I'm joined by key representatives from Guy's and St Thomas's Hospital Trust and King's Improvement Science who've carried out this work, and I'm going to ask them all to introduce themselves in just a moment. Now, putting remote monitoring into the context of our daily lives, we have over a long period of time now been gradually having the routine processes that we need to perform on a regular basis converted from manual, paper-based activities done or face-to-face by phone or email to being done digitally online. Think of banking, online shopping, booking holidays. So many of us are used to doing these things digitally, but perhaps not yet quite so much in regard to our health. We do now, of course, have the NHS app, and we can book GP appointments online and reorder prescriptions and so on. And there are loads of health and fitness apps out there that we can access if we want to. However, whilst health monitoring in many specialist niche areas can be incredibly sophisticated and powerful, most of us probably don't yet have access to a basic electronic health record or fill in patient questionnaires on a regular basis via a computer or a smartphone to let our healthcare teams know how we're doing between appointments. So I'm really pleased to be joined by the team from Guy's tonight and King's Improvement Science, who have undertaken some very innovative work in this area of remote monitoring of people with RA across South London. And we're going to hear about what they've done, how they've done it, and what the results of this work are. So, team, can I ask you to introduce yourselves? Toby, can I come to you first?
Yeah, I'm Toby Garood. I'm a rheumatology consultant with Guy's and St Thomas's Hospitals in London.
Great. And Emma-Jayne, you next on my screen.
Hi, good evening. I'm Emma-Jayne Adams. I live with rheumatoid arthritis, and I'm a patient representative on this project.
Great.
Patient at Guy's Hospital.
Thank you.
Good evening, everyone. I'm Mary-Ann Palmer. I'm also a patient representative. I too live with rheumatoid arthritis.
And Helen.
Hello, everyone. I'm Helen Sheldon. I'm an evaluation manager at the Health Innovation Network.
Great. Now, you're all going to do some short presentations before we get to the Q&A session, which I think is going to be really interesting. Got a lot of good questions for you. But Toby, I think we're coming to you first to tell us about the service and what you did, and then we're going to come to you, Helen, after that. Over to you, Toby.
Thank you very much, Ailsa. So, well, thank you for asking us to present this. So, I'll just give it a background to this. So, we some years ago we were working with a design agency. We were taking a novel approach to service redesign at Guy's and St Thomas's, and this is a process which takes a really deep dive into user experience of a pathway or of healthcare, with a particular emphasis on patient experience. And a lot of things came out of that, but one of them is exemplified by this slide. Yeah, so we exemplified this slide. So, and we tend to frame the problems we're trying to solve in what we call how might we statements. And this was around how do we make better use of our clinical capacity? So how do we make sure that we are seeing patients who need to be seen and not seeing patients who don't? And anyone who's a long-term user of the NHS will know that sometimes you have to go to hospital when you haven't really got anything particularly to complain about. But other times it might be slightly more difficult to access urgent advice when you need it. So we were trying to think, well, how might we do this differently? And something which became very evident during the pandemic, and I have to say this we started this before the pandemic, was that you could actually do things differently. And with the widespread and large-scale cancellation of appointments, we we found that we're able to operate a safe and pretty effective service by offering a much more responsive model of care. So making sure that we actually did see patients that most needed to be seen, whilst keeping those who are well away from hospital, but also keeping them safe as well. So when we looked at this and we thought, well, this is back to what's quite an old idea of asking patients to tell us how they are when they're not sitting in front of us. So how do we get information from patients which can give us information about how they are on a more regular basis, as opposed to just telling us on the once every 6 months, or maybe when they come to see us in hospital. And this idea has been around for some time. I've been doing rheumatology for probably at least 20 years, and it was certainly an idea which was in its infancy when I was a registrar, and certainly over the last couple of decades there have been numerous attempts at doing this, but I'm not sure that we're particularly good at learning from experience over time. So the aim, as I said, was to think, well, how do we get data from patients? How do we keep well patients out of hospital? How do we respond really quickly to patients who need us? And how do we use this information to actually inform clinical consultations? And I'm going to try and change my slide now, and I can't. Can someone change it for me? Next one. So we kind of started by thinking, well, what might patients want from this? And we wrote a long list of things we thought patients might need from this, such as giving us detailed information, having graphs of these activity, medication lists, reminders to take medication, so forth and so on. And at a very early stage, we went out to our very, very helpful patients at Guy's and Thomas to say, well, what might you want from this? What are the problems we need to solve here? And next slide. What we found was that next slide. Yeah, what we found, actually, this isn't what they wanted. Next slide. What people actually wanted was something much more simple than that. People wanted whatever we do to be simple. They wanted to be accessible, and they wanted it to feel human. And that's actually quite a different design challenge to trying to put all this functionality into something. So how do we do something which makes people feel looked after and safe? So we spent a lot of time with an external agency who helped us form that into some ideas around how you might do this with patients. And it started off with prototyping the model on bits of paper and putting that in front of people, saying, what do you think of this? And only when we thought we had something which is workable will we then try and prototype it and start to build working models which really worked for patients, but also worked for those of us at the other end of the system. And one of the key things that people wanted was some sort of feedback. So people don't want to be filling in forms like we often do when we're asked for feedback for this, that, the other, to feel that no one's really seeing it. So people wanted to know that if they were going to give us information, that we were looking at it and taking note of it and doing something useful with it. So that was a really important part of the design process. What we all want to put in there was a way of communicating with the team, besides just giving us the information we'd asked for. I'll come on to that very briefly later on. But it also had to be dead easy to use. What we often find with systems, particularly they're designed by the NHS, so they are far more complicated than they need to be. And we want this to be something which people felt would take as little time as possible to use, would provide us with meaningful information and information which matters to the patients, but was also as frictionless as possible. So, for instance, we found that, unsurprisingly, the best way to access somebody is by sending them a text message. And we did find that people are less keen on apps. And I think as you think about the long-term future of digital health, it is difficult to imagine a world where as we all get older and acquire more conditions that we're going to have a different app for every condition. So we wanted to keep this simple, not require people to download things, because even by doing that, you create a barrier to people onboarding themselves. So we just mediated through text message and created a form which was very easy for patients to use, which I'll show you briefly in a second. But also we wanted to make it very, very easy for clinicians to use as well. Anyone on this webinar who's familiar with NHS IT will know that we don't make it easy for ourselves. And some of the systems we design are quite old and quite clunky and quite difficult to use. We wanted to make this a joy to use. So we didn't want anything about the system itself to get in the way of people using it. So that's where we started. I'll just show you a couple of screenshots of what the system actually looks like. So this is the onboarding page. So this is the page that a clinician will use to add a patient to the system. And all we need is the patient's name, their last name, the NHS number. We've got to have some unique ID there. Their mobile number, just below that is a diagnosis. And that's it. And that's the bare minimum we need to get somebody onto this system. But it's enough. That's all we need to know about someone to get them on board. And as soon as we put someone into it, that patient will get a message saying, welcome to the system, explaining more about it. So what they'll get beyond that is, I'll show the next slide, is once a month is an invitation to complete a questionnaire. This is what's known as a patient-reported outcome measure, a PROM, which are increasingly used in healthcare to help us get meaningful, useful information from patients who aren't sitting in front of us. This is something called the RAID, and this is a questionnaire which has been validated, which basically means that it's been shown to be representative of a patient's clinical condition in rheumatoid arthritis. And there are 7 questions in there from 0 to 10, and we've optimized this for mobile phones and for people who might, for instance, have difficulty using their hands, to make it easy to use. And it's got a number of questions around things such as pain, disability, sleep, emotional well-being, coping, and a couple of others. So it gives us a multi-dimensional picture of how somebody is at a point in time. What it actually produces, as well as the individual scores, is an overall score. And we know that correlates quite well with disease activity, particularly if patients are in remission. So if somebody has got a low score on the RAID, then they are very likely to be in remission, and that gives us some reassurance. Let's go on to the next slide. So this is what we get from patients. So patients are asked to complete this once a month. We did quite a lot of work to understand what is it that will make people or encourage people to complete this. And as I already said, there's something about the feedback loop. There's people knowing that this is got a human being at the other end of it, but also there are things about the way we message people that encourage them to respond, which is really interesting. Because we do know if you send an unsolicited message to someone to get them to give you some information, in healthcare, it tends to be about 30%. Elsewhere, it's even less than that. So we found, for instance, that if that message is labelled as coming from the NHS, that makes a difference. If it is addressed to you, so it says rather "Dear Toby," for instance, rather than it appears more anonymous, that encourages people to respond because it appears personalised. And we also found that sending reminders is really important. So about 50% of people will respond after one invitation. We send another invitation out, another 20%, we get another 10%, and so on. So 2 or 3 reminders really important to making sure that people get the opportunity to submit this to us. So this is what we can see in clinic, and this is incredibly helpful. So we can get an overall score. So when I'm in clinic, I will turn the screen so we can both see it and show someone what they've been telling us. And we can look at the overall score over, in this instance, several months, and then we can break it down. So we can break that under individual components. So for instance, I might want to look at someone's emotional well-being, their physical well-being, their sleep, fatigue, and so forth. And what we do find, what we're all not very good at, is remembering how we were 6 months ago. And this again adds real value to consultation. So people are often quite stoic and say, well, I've been fine, doctor. But then you look at this and say, well, actually, there was a blip 3 or 4 months ago. What happened there? And people say, oh, yeah, I've forgotten about that, and such happened. And that can really help you think about how might we get better disease control over time. But sometimes it's something unrelated to disease activity. Maybe they've had some emotional difficulty or some mental health problems. And much more now than before, I find myself having that conversation with people, talking about their overall health and mental well-being, and it will help us to explore together how we can support that and make sure that people are pointed in the right direction for support. Let's go to the next slide. So this is just an example of how you can overlay the overall score in purple with, in this instance, fatigue, which is this particular patient remains troublesome. So that would be a very important point of conversation for this particular patient. If we just go to the next slide, this is just very briefly shows where we are. So we've got about, oh sorry, I've lost, there we are. We've got about 2,000 patients on the platform at the moment, which I think is one of the biggest cohorts of arthritis patients who are monitored in this way, certainly in the UK. And what we found is that people continue to respond. So over time, this data itself is a little bit old, but about 70% of patients a month respond with, which is pretty good. And often people struggle to get high levels of engagement. We do find that when people are well, they tend to drop off. And I'll always say to in clinic, well, I haven't been filling it in, and so I've been well. There's no point in me telling you. But the point is, it's really helpful to know that. It is useful to know that someone has been well. So what do we do with this? Let's go to the next slide. So what we have is a number of opportunities presented to this. So first of all, in the simplest form. Get the next slide. Is there a next slide? That last one. Oh, sorry, I've got an extra one here just to help me. So you can maybe take the slides off now. So in the first instance, we have a way of informing a clinical consultation. So I can sit with somebody, I can look at how they've been over 6 months, over a year, or even over the course of a few weeks, and look at how they've been. What's the overall health been? What are the components of that been? It really helps to inform a useful conversation to think how we might improve holistically their health as we move forward. Secondly, we have a remote monitoring component to this, as well as us giving us information for clinical consultations. We have an arm to this, or an arm to this platform, which enables us to actually track people dynamically over time. And so if somebody remains well, the system will leave them alone. But if their score goes above an expected threshold, so they're flaring, the system will highlight that to one of our administrators, who will in the first instance contact the patient by text and say, you haven't been so well, is everything okay? This is how you can seek support. But also we can specifically signpost people to, for instance, advice around fatigue. We can link them to our service page on the internet, which actually allows patients to book an appointment themselves with a nurse to have a conversation. The system will also allow patients to send us text messages. Whenever you complete a form, it also invites a contribution by text messages as well. So there are numerous ways for us to track people, pick them up if they are flaring, send them some advice, and put them in touch with our clinical team. What we have at Guy's and St Thomas is you have multiple portals through which patients can contact us. They can telephone, as always, leave a message, and they can send us an email. They can go to our website and book a telephone call. We release appointments every day, so patients can book themselves an appointment within 24 hours. And also they can send messages through this platform, so we can have two-way conversations with them through the platform. So this informs clinical consultations. It helps us to monitor patients when they're not sitting in front of us, so we can pick up patients who are not well. We do know that patients often don't complain when they're not well, so this helps us to actually reach out to them and say, is everything okay? Can we help? But also, if they're well, it helps keep them away from the hospital. And as we might mention later on, I might say something about PIFI a little bit later on. And now, so what next? So we're looking at how we might actually use this to start to create a genuinely more dynamic approach to how we organise our clinics and our clinical capacity. So we've built this into a model which we just started trialing this month, which will look at the patients coming to see us over the next month, and it can predict which patients are less likely to need an appointment. So patients for whom it looks like things have been okay, things have been quiet, they may not want to drag themselves into the hospital. Of course, often a telephone appointment instead, but they may prefer not to do that, in which case we can release that appointment to somebody else. So the model is now that we are using this to predict which patients appear to be well. We'll send them a message saying, it looks like things are going well. Would you like to defer your appointment by a few months? So we're just starting to try that. And you watch this space, hopefully I hope we'll be able to publish something on that before too long, but we're very keen that we share learning from that as soon as we can. So I think this is a genuine step change in how we organise our clinical capacity and actually offer real added value to patients. And just finally, we are looking at how we add in other components to this. How can we start to get other bits of information for patients? And one thing I'm particularly keen on is mental health, because we know that mental health is it's prevalent in our general population. It's prevalent, of course, in people with arthritis. And we do know that if you've got mental health challenges, it can make pain harder to deal with. It make it hard to get to hospital appointments. It can make it hard to take your medications. So it's really important that we're very, very mindful and aware of mental health problems that people are facing. So that's what's next for us. But I'll stop there. I hope that's given a reasonably concise.
Yeah, really, really interesting. Thank you for that. Helen, we're going to come to you next and hear about how the service has been evaluated. So, Anita, would you kindly load up Helen's slides and move on to the first slide?
Thank you, Elsa. Thank you, Toby. Really great hearing you talk about the service like that. I don't think I've ever heard you just sit and talk about it. It's been really interesting. Thank you. I work for the Health Innovation Network, which is the Academic Health Science Network for South London. The Academic Health Science Networks are the bits of the NHS bodies set up by the NHS to support the spread and adoption of innovation. So I started working with Toby in 2019 to evaluate the remote monitoring service that they'd developed at Guy's, and in particular to evaluate the rollout across South East London. We quickly joined forces with King's Improvement Science, and one of the benefits of this collaboration was the opportunities that it provided to involve patients in our evaluation. And we've got Mary-Ann Palmer and we've got Emma-Jayne Adams here, who were two patients who worked with us. I'll come back to that in a moment and tell you a bit more about that. But before that, I'd just like to tell you a bit more about the evaluation. If we can move on to the next slide, please. So what we wanted to know was, what's the service like for patients, and what's it like for staff to use the remote monitoring service? We wanted to know what made it easier to implement this new service and what the sorts of things that got in the way. And how we went about doing that was we reviewed the existing published literature, and we did that by analysing, we also analysed data from the service level data from the remote monitoring system itself. And we conducted a patient survey, and we conducted interviews with patients, and we also conducted interviews with staff. And moving on to the next slide, I mentioned that the collaboration with King's Improvement Science allowed us to really involve patients actively in our evaluation. The other thing it enabled us to do was to work very closely with NRAS, and the partnership with NRAS enabled us to recruit patients to work with us on all aspects of the evaluation. So as well as Mary-Ann and Emma-Jayne working with us, we had some other patients who were recruited through NRAS. And those patients worked with us through the whole project in the design, right from the design phase right through to the writing up of the results. And Emma-Jayne and Mary-Ann, as they'll come on to tell you in a moment, were more closely involved in the evaluation. And moving on to the next slide. So if I can start telling you a bit about what our evaluation found. So looking at the existing evidence, so our literature review found very promising results from about the use of remote monitoring in rheumatoid arthritis. But what we found less of was what actually makes it possible to roll out services across in real life, in the real world, and the sorts of things that act as enablers and barriers. When we looked at the numbers from the service level data, what we found was that a very high proportion of the patients who enrolled in the service stayed enrolled. So once patients started using it, they carried on using it. So really good sign. What we found that many of the patients who used the remote monitoring service were registered to use the remote monitoring service. They filled in their questionnaires, their RAID questionnaires, the questionnaires that Toby showed you earlier. They filled those in really quickly when they were prompted. The other thing we found was that most of the patients that were involved in the service and registered were from the pilot hospital. As I said earlier, it was the service was being rolled out across South East London, but we found less patients were enrolled from outside of the pilot hospital. So the next slide will tell us, so tell you a bit about what we found when we interviewed patients. So the key message from our interviews was that patients really liked the system and they found it easy to use. Toby was telling you earlier about all the work that went into making the service user friendly, and it was all those things really showed when we talked to patients. They definitely found it easy to use. COVID-19, this is happening obviously at a time when COVID-19 was hit us, and it was a motivator. It helped patients like the fact that it could help them avoid going to hospital. The other thing patients really liked was the fact that it enabled them to contact the clinical team more easily. It gave them another route. So it didn't replace their existing care, but it enabled them, it gave them another route, and they liked the free text message feature in the system. So moving on to the next slide. The other thing that we were interested in finding out was what sort of impact the remote monitoring system had on patients' ability to self-care or their willingness to self-care and to self-manage their condition. And the results here were really reassuring, really promising. Patients were talking about increased self-awareness. They were finding it easier to self-manage their condition. And part of that was about being able to get help when they needed it. And moving on to the next slide, the story from staff was different. Staff found it easy to use and found it helpful, but there were also concerns. So COVID initially was a positive factor, but as time went on, the pressures that it put the system under created more difficulties. There was a worry about increased workloads from clinicians and about the impact of digital exclusion. So what about the people who weren't able to access the system? What was the implications for them? Another feature that clinicians saw as a barrier was the fact that the data from the system that didn't integrate with the existing electronic notes system. There's a lot on this slide, and I want to give time for Mary-Ann and Emma-Jayne to talk. So I'm going to quickly move on to the next slide, which is just a summary. So in summary, patients had overwhelmingly positive experience, and that does, as I say, really go back to all the work that went in with patients to develop the system. Clinicians' views were more mixed. And I think as the work that we did, we concluded that it was largely due to clinicians' views not being prioritised highly enough during that development phase. So, although it was great that the patient view had been prioritised, it did have implications in terms of the rollout at other sites. So I think, and we concluded that it was important to remember that those clinicians are another key user for this remote monitoring service to work properly and sustainably. So they really have to be involved in the development phase. So what does it all mean? So when remote monitoring works, it really works well, but scaling up can be hard and depends on looking at the local hospital context and needs, and also taking things slowly and not doing too much too soon. And finally, just to say thank you very much for listening, and I think we'll come back to questions later if you have any.
Great. Thank you very much. Very, very interesting. And I'm particularly interested because I'm working on a digital rheumatology project in Scotland, and we're just about to start doing a live simulation with volunteers. So I'm making notes here. So let's come to Emma-Jayne first, and let's hear from the very important patient perspective. Were you involved right from the get-go, Emma-Jayne?
Yes, pretty early on. So I thought it'd be interesting to just give you some of an insight into my experience actually using the service. Because as I suggested, so I was actually asked to whether I'd be interested in joining the trial back in 2019 after just a routine RA appointment at Guy's Hospital. And so I remember at the time, sort of my actual job was working on global corporate digital projects. I remember thinking, wow, this is really modern for the NHS. This is quite interesting, especially as at the time I was having to email my blood test results from my GP to the RA team so they could review it every 20 weeks. So yes, I was very keen to get involved and see how it could help me and my experience. And so, as Toby has mentioned, the survey is accessed by the link, by text message every month. It's really, really easy. I get mine early in the morning, which is brilliant for me because I drop the children off at school. I then come back, sit down, grab a cup of coffee, and just take 5 minutes to plan my day, and I can answer. And if I don't forget that, if I don't remember, that reminder is really helpful because it keeps on coming until I complete it. And like Toby said, you have to rate it out of 10. And I must admit, in my experience, this can be tricky at times because I think for me, I'm a positive person. So I'm never really going to answer a 9 or a 10, probably. However, I do think that the scores reflect how I'm feeling and how I'm doing at the time to the clinicians. So it's really quick to use as well, I should say. So self-managing, in addition to my medication, I do self-manage, and I've been doing so for a good few years through nutrition and exercise. And I think this monthly survey actually supports it because it gives me that space and time each month to sit down and think about me and my health. I was diagnosed in my early 20s. So, I've had a busy career, got a family, children, etc. And I think you get caught up in that juggle in life where you just sort of go through the flares and just keep on going, don't really think about them, or you can do. But this means that I sit down and actually think whether I'm well or whether I'm flaring, what's been happening, what have I been up to, what have I been eating, am I stressed, etc. And I can make those linkages. And that graph at the end is really, really important. It's really interesting because you can see those fluctuations and those patterns. I just wish you could download it, Toby, so that you could bring it along yourself to consultations and use it. So yeah, I think it's helped me to self-manage my RA a lot better. Using it in clinic, mentioned, I don't know if all the clinicians use it, but in my case, they do. I always mention to my consultant or my nurse when I'm having one-to-ones that I'm on the trial. They always bring up the results. And like recently, it was quite clear that my biologic wasn't working for me. So the digital pathway coordinator who looks at my scores sent me a message saying, please, can you get in contact with the nurse? I did so. I then had a one-on-one and I got a new biologic prescribed quite quickly, which was brilliant for me. I didn't flare for too long. So the last thing I think is the contact with the team, and it's not always easy to get in contact with your RA team when you need to. During the pandemic, I felt quite isolated. I was shielding, but the remote monitoring service did actually make me it was reassuring to know that I was being monitored and that somebody was there should I need them. And that two-way communication aspect is something I found out during a feedback session early on with the development team. But it was vital. During the pandemic, I unfortunately got COVID. The joys of sort of kids going back to school during the pandemic, and it was going to happen. But of course, my GP didn't know what to do, unfortunately, didn't know about the treatments. I couldn't get through on the phone to the RA department or email just because everyone was so busy. And it was quite urgent. I knew that I needed to get the treatment. So I literally just sent a text message to the digital coordinator. She then flagged to the clinical team, and literally within 24 hours, I was being given the antibody treatment. So I'm really lucky I didn't get really seriously ill like I could have done. So I think my own personal experience is that the service has been good to date. It's very positive. And I think it's a vital connection to my team at Guy's. So, thank you.
Thank you. Very interesting. So Mary-Ann, was this your first experience of getting involved in research like this? How did you get involved?
Just to say, I've been using the remote monitoring since it started. So I was very keen and interested when I heard about it. But I'm here this evening to tell you about my experience of being part of the research rather than just the experience of using the remote monitoring service. Now, I've always been a very curious person. Some people may say I'm rather nosy. And my hobby really is always to find out more. I always want to know more. I'm very interested about, whatever my current preoccupation is, I want to know more. I will go out of my way to find out. And so in this case, my preoccupation obviously has been my RA. But before the pandemic struck, my hobby was studying psychology in my evenings after work. But then my diagnosis of RA came just as I was finishing the course. So in fact, it was a bit sad. I had to give up my studies, and I actually retired from my job because my condition was rather severe and it just wasn't stable enough to carry on. But forward a year, and this opportunity arose to be part of this research team. So I have had a little bit of research experience. Obviously, I did some research as part of the psychology work that I was doing. And also other areas where I've been interested, I've done research. But so it was great to be asked to be part of the team. But I have to say, I was a little bit apprehensive despite my previous experience. But really, I needn't have been. The team have been absolutely great. They've been generous with their time and their patience, and they're really helpful. Helped me get to grips with the methods of working and the models which have been used for this research. The sorts of models they're using, they're really quite particular to the world of research. So it did actually take me quite a lot of consideration, and it took me quite some time actually to do the reading, but I was interested. So that was great. There are some similarities actually with doing research for this sort of clinical work and what goes on in your general working life. So for instance, working within a budget is important. I guess it's no surprise to anyone that the NHS is a bit cash strapped, but it was nice to be paid for my time. And I don't just mean for the time I've spent working in meetings, but also my background reading, working on the project methodology and reviewing things like interview scripts and the actual results of the research as it's come through. Another similarity perhaps that I'd like to talk about is the need when you're working in research like this is to have good, strong teamwork. And for me, that's been a really rewarding part of this research. So even if the other trusts don't take this sort of remote monitoring forward, it's absolutely great to hear about the talented individuals who've been on the team who are really trying to make a difference for us patients out there. Now, if you were to ask me what was the least enjoyable thing about the research, I'd have to say it's the time it takes to move through the different stages. Now, I think maybe some of that is because I do lack patience. I am not a patient, but more likely it's because the project, you have to remember that it's not the only focus that the team members have got. They're working on a lot of different things, including, Toby's obviously a clinician, and Helen's got lots of other projects that she's looking after. So also we have had some team members move on, but overwhelmingly, I really have enjoyed my time working with the team. I think it's fair to say that both Emma-Jayne and I have enjoyed it so much that we now participate in another patient group where we can comment on and input into other clinical projects. So it's great for someone who's really nosy like me. And I'm still hopeful that someday I might see my name in print. Toby.
Fantastic. Well, thank you very much. Really interesting to hear everybody's different perspective in this work. So I'm going to start off, I think, with a question for Toby. You've told us a bit about how this work has affected your clinical practice, and also that you're looking to change a few things and to develop the program further. Are there any other changes that you would like to see going forward? You've talked about the mental health, and you've talked about the dynamic tracking of looking at predicting which patients are going to do well and not so well, and so on. What about anything else? And would you also, thinking about things, would you want to go back, or is this something that you see as being a permanent fixture in the way you run your clinical service going forward? And would you want all of your colleagues across the trust to be adopting this kind of remote monitoring? Sorry, a few questions all in one there.
That's right. Well, I mean, personally, no, I wouldn't want to go back. I think if I mean, I think it's, as I mentioned, it's got multiple facets to it. But I think having that continuous data about somebody when you're talking to them is incredibly valuable. And I do think, particularly in the current climate, when access to healthcare across the board is more challenged than it has been, I may be the only doctor that someone's seen for a while. So I kind of think it's my duty to make sure we have covered more than just the arthritis. And I think mental health and sleep and fatigue, all these are really, really important. And I think so. I think it is essential that we do consider somebody in the round. So I think for that reason, it's vital. I also think that we do need to be moving towards more dynamic models of health. I think making sure we see people when they need to be seen. Because if we don't, in extremis, people will go to their GP or they go to the emergency department. And I think being able to just scoop people up and look after them in a moment of need is really, really important. And I think that responsiveness is something which we've learned a lot about during the pandemic. So I think this will help to inform that. And also the concept of patient-initiated follow-up, which is kind of what we're describing here, is the idea that you keep patients really out of hospital for as long as possible, but making sure you've got that responsiveness. So this is basically what we're doing here. But the idea of patient-initiated follow-up is something which is a priority for the NHS. So there's many reasons why we want to continue to do this and learn more about how we actually deliver better care. In terms of what else, I mean, locally, we've got a new electronic record coming in a few months' time. So there's no need for us. We're trying not to do anything which that record might duplicate. And if the record could do all this, then we wouldn't need this particular platform. We have thought a lot about how do we use this to help people look after themselves. So, for instance, making sure that we're looking at cardiovascular risk and we're looking at bone health, and we're looking at mental health. So we have thought a lot about how do we actually make sure that people are, I guess, for want of a better word, nudged periodically to make sure that someone's measured your blood pressure somewhere, someone's looked at your bone health every so many years, and so that kind of thing. So yes, there are lots more things we could be doing with it, but we have focused very much on trying to do what it does at the moment really well, and I think we have managed that.
Can I just put a thought into your head when thinking about, evolving the service? And that is using the third sector, organizations like NRAS, because often a patient needs information, they need a bit of reassurance, they need a bit of picking up because they're feeling low, things that don't necessarily have to be delivered by a clinical team, but can be delivered by professional patient organizations who do this kind of stuff day in and day out. Having a direct link to a patient organization as well as to the clinical team might be something that you could think about.
I couldn't agree more, and NRAS are fantastic. We're talking about just that this afternoon, actually. I've got another role, which is joint medical director for South East London Integrated Care Board, and something I've learnt in that role last year is the extraordinary array of third sector organisations out there. And of course, there's the ones I know about, NRAS, but there is a fantastic array. And I think, generally speaking, the NHS, we don't avail ourselves of them in the way that we could, both in terms of what they can offer us, but also in terms of giving us intelligence about how to, what patients need. So absolutely, couldn't agree more.
Great. Okay, so a question for Emma-Jayne and Mary-Anne. What came across in the presentations, excuse me, was that whilst the patients were very enthusiastic, there was a little bit of reticence on the part of the clinicians, understandably, given the timing of this during COVID. But why do you think that the patients were more enthusiastic about the service than the clinicians? Have you got any insight on that?
I think it's because it's absolutely personal for you. You're the one in pain. You're the one, that you're considering generally. Whereas the clinicians have got dozens and dozens of patients, some of whom are remote monitoring, some of whom aren't. So, they're using lots of different systems. They're not just using the one very easy mobile phone activated survey. It's a lot more difficult to be a clinician, truthfully, than it is to be a patient in that regard.
Yeah.
Definitely. And from a patient's perspective, like I mentioned, you've got that reassurance that, in the past you'd go sort of monthly, maybe a year between your appointments at the hospital, but now you've got that monthly check-in, so you do feel like you're being looked after, you're being monitored. Give you that reassurance, and it's a good thing if it helps your treatment and your experience.
And what about your thoughts in terms of inclusivity and inequalities and so on? What about the people who really don't have access to this kind of technology and just, or may have access to it but can't use it for whatever reason? Do you think that this system would free up the clinicians' time to make, to give them more time to look after people who aren't going to engage with this kind of system, who aren't going to be on those PIFU pathways? What are your thoughts there?
Yes, I think so. It could be. I was actually quite surprised because we sort of approached this in discussion during the research, and I was actually surprised about the number of people that were engaged. I was concerned that people wouldn't have access to mobile phones or use the internet, but there was a section of patients who they might not use a mobile phone themselves, internet, but they had a carer that could do, and they had that support there. But yes, the patients that do need that additional sort of one-to-one support, the clinicians will have that ability, hopefully, in the future to be there for them.
Yeah. Can I just come to you on that one as well, Toby? Do you think that this will give you more clinic time to be able to give to the more complex patients who aren't on PIFU pathways and those who perhaps can't engage with this kind of thing?
Yeah, completely. I think the way to get the best value out of healthcare is to spend more time with the right people, and so that's really important. And I think, sorry, I forgot the question.
It was just really about access to
sorry, of course,
technology and inequalities. We know very well that the inequalities are still there, very writ large.
Yeah, for sure. I mean, health inequality is a huge challenge, and we are all very, very mindful of that. So one thing my research fellow is looking at with this: what are the predictors of engagement with this? So people who are able to use it, who are those people? Who doesn't use it? And then with that, labels focus our attention on that.
Right.
But no one solution is going to be right for everyone. But what this does is it frees up other channels. So we've now got fewer people using the helpline, for instance, leaving a message. So it means that people who will rely on that have far better access to it. And so it's about that. We've got, I think, at least 4 channels patients to contact us. So different ones work for different people. It doesn't mean that everyone does have. We can try to optimize what works best for them.
Yeah, and can I also ask you why you think that this service was so appealing to guys, but less appealing to the other hospitals across Southeast London, and maybe therefore the patients in those other hospitals perhaps didn't get as much opportunity as they might have had because the engagement was less. Why do you think that was? What are the challenges? Yeah. Because I'm keen for us to understand the warts as well as all the benefits of this kind of thing.
So I didn't dwell on that. When we first launched this, we tried to launch it across multiple hospitals, and the idea was that we would be able to curate and monitor people's arthritis centrally in one place. And we were very ambitious with that, very over ambitious. I think there's a number of steps. So the first was introducing new technology, and to do that, you've got to own it, and you've got to have someone in the next room championing it and saying, "Come on, guys, we're going to do this." And if it's another hospital, you haven't really got that. But on top of that, you need to again have that force behind you, making sure that patients are engaged and they've got support. People encouraged to actually use it in clinic once they've been onboarded, but also. I think the idea of other people monitoring your patients, that requires a lot of trust and confidence. And it's not that we don't trust each other, but you've got to trust the system. It's got to be established. You've got to know what it means. So I think trying to do everything at once, and a really important message for us, probably is the wrong thing to do. I think you've got to start with the idea, and then get the technology working, and then somewhere downstream say, okay, how about we actually start monitoring each other's patients? And that's interesting, a completely separate project, something we're thinking about with virtual wards, for instance. But it is something which creates an incremental process, because introducing new technology does require building a lot of trust from all parties. And I think we probably underestimated that. But 4 years in, as I said, we got 2,000 patients on it, and now would have been the time to do that.
Yes. Okay. Impressive. 2,000 patients. Maybe I can come to Helen now with a couple of questions. Do you think that lessons from the evaluation have affected how you would try and introduce this kind of change in future with other studies?
Really good question. I think one of the key things for me, and one of the really exciting things for me about working on this project with King's Improvement Science was the way that we were able to involve patients in the team. So in the evaluation team, which indirectly were in a way directly able to influence the delivery of the service. So that was one key learning for me. The other thing I think probably might be a little bit sort of outside of the area of interest of most of the people on the call, but one of the things we did from an evaluation perspective was work with theoretical models, and that for me was great, and certainly I learned a lot about how using a structure, a theoretical structure, can enable you to very quickly identify what's going to help you with your implementation. So when you're implementing when you're implementing innovation, if you're working within a structure, and that will quite quickly tell you what the sort of key things that you need to ensure are in place.
Interesting. Okay. And what happens to the findings now? I know we're planning to help with some of the dissemination through our magazine and so on, but what else is happening in terms of disseminating the results of this work?
Yeah, so we've had a poster shared at an international implementation conference in Switzerland at the beginning of June. So we've had that. We've had conference papers at UK implementation science events. We've got an article that's with the reviewers at the moment that we're hoping will be out and published before the end of the year. It takes a long time, as you know, but it will happen at some time. In the meantime, we're concentrating on quicker ways of disseminating the findings, like your event tonight, which has been great.
Yeah, I mean, it's great that you're progressing with the service, and it's actually real, and it's in clinic, and it's happening. Because one of the things that I sometimes find a bit frustrating is that researchers present great work, and then it doesn't go anywhere, and you think, well, let's get some of this stuff implemented before you go on to the next research project, because it's implementation, I think, is key, and it's great that this is actually in clinic and happening and continuing. What can I ask all of you in turn? Maybe Toby, you go first. What would be your key pointers for researchers or clinicians thinking about involving patients in their work?
Well, I think most importantly was understanding patient experience and the unmet need. So I think people will help you if you're going to help them. And so I think for this, it's been a very much a two-way thing. We started by really trying to understand what we needed to do to make people's lives better. So that's been incredibly informative for us. Something I'll just throw in is this: I didn't go into details here. This was funded by grant funding. we did build the platform ourselves. And the reason we did that is because there wasn't anything out there which was as simple as we needed. Everything out there we thought was too complicated. So it's non-commercial. It's owned by the organisation, by the hospital. And if there is any, and as I keep saying, and when I talk to, if there's anybody out there who wants to try it, any clinical services want to try it, we'd be more than happy to share it.
Thank you. For Emma-Jayne and Mary-Ann, what would be your recommendations for anybody, any patients out there watching tonight who have maybe not dipped their toe into getting involved with research? What would be your thoughts and recommendations?
Do it.
I agree with that. But you do need to be able to allot a little bit of time to get yourself up to speed with speaking the sort of research language. If you're not used to it, then they do use models and constructs which you don't use in your everyday life. So you have to be prepared to learn a bit as well. So and allocate the time to do that.
And to have just ask questions. So, for example, the first few meetings we had, it can be quite daunting being around, consultants, amazing researchers.
Aren't they?
Oh, they're terrible. They're terrible. But it's, it's lovely. They were so supportive and patient. And we asked a lot of questions, definitely for the first 6 months. Sort of, what's that acronym mean again? And what's that? And
it's a different language, isn't it?
It is a different language.
Okay, well, I think I'm conscious of the time. We just got a few minutes left, and I just want to mention a few things coming up from NRAS. But first of all, thank you all very much indeed. It's been fascinating hearing about your work, and may it go from strength to strength. So we will be, this is recorded, as you know, this live event this evening. It will be, you will be able to watch it back on our YouTube channels and I think our other channels, Facebook and so on. We will have information on the website that will be there for a while. So if anybody wants to find out more, please do go to the website. We will be running an article on this work in our September magazine, which will be coming out on the 1st of September. So you'll be able to read more about it then. Other things coming up, we have JIA Awareness Week from the 3rd to the 7th of July. Please do go on to the JIA website, that's jia.org.uk, and take our JIA Myth-Busting Quiz. There's lots of activities that you can find out about and you can get involved with and support. So please have a look at all of that. As you may know, we run our NRAS live events on a monthly basis on the last Wednesday, usually of every month. Our next live event is on the 26th of July, and it's going to be all about foot health. We've got in August, our live event will be on research and COVID vaccination update for everybody. Because whilst the pandemic might be over, COVID goes on, and we still need to be knowledgeable about what we need to do to keep ourselves safe. We will be doing another update on PIFU. We've already done one session on PIFU, but we'll be doing an update on what's happening there later in the year. And in September, we will be with Professor Ian Giles talking about the new BSR pregnancy guidelines, because they have changed and it's important new information for anybody interested in starting a family. So please do join us for our future live events coming up over the summer and the rest of the year. In the meantime, thank you all very much indeed for joining us this evening. Thank you for watching, and good night.